Chapter 14, the secondary assessment. So this is a lengthy chapter with a lot of good information, but for the purposes of the online discussion here, I'm going to skip through a few chapters. We're going to get into really the meat and potatoes. The first few, or the first section, first handful of slides discusses specific assessment components of each individual body system. Those things are important, but those are all things that we will get into in more detail as we discuss each of those individual body systems chapter by chapter. So I'm going to go through more methodically the process of assessment, specifically the secondary assessment, and get into some of the details of how we can be most effective in doing so. So if you're following along with the PowerPoint at home and you notice that there's some slides that get skipped in this presentation, that's by design, and we'll discuss that more in class. So talking about the secondary assessment, that is now the third component of the overall assessment algorithm. We started with the scene size up and all the components contained within that, including the scene safety, taking appropriate BSI precautions, identifying the number of patients, requesting appropriate resources, and determining the potential mechanism of injury or nature of illness. From there, we transitioned into the primary assessment, which is more of our hands-on component of the patient, as we identify the patient's mental status and their ABCs, along with our general impression, and determine a transport priority. From here, then, we move into the secondary assessment. And the secondary assessment is really comprised of three primary categories: the physical exam, patient history, and vital signs. Now, the order in which you do these things is discretionary to you. You're allowed to kind of jump around and modify this as you see fit based on your primary assessment of the patient. Understand that the order in which you do things, you need to be focused on coming up with a differential diagnosis. So simply rolling the dice and choosing to do one thing before another is not acceptable unless there is a specific focus that you're trying to accomplish. And in this case here, what we want to do is try to always identify what the underlying cause of my patient's conditions are. So for instance, in the vital signs chapter, we talked about how vital signs don't really tell us what's wrong with our patient. They offer us some basic symptoms. They give us some indications as to the condition of my patient, whether or not they're stable or critical, but they don't truly tell me what the underlying cause is. And that's what we need to identify. We need to try to identify that underlying cause, treat it if at all possible, or at a bare minimum, notify the hospital and make sure that we're transporting to an appropriate facility that is capable of treating that patient. For instance, simply identifying that a patient is short of breath does very little for us. That is a symptom of an underlying problem. If we can determine that the patient is short of breath due to asthma, compared to a patient who is short of breath due to a heart attack, those are two very different treatment modalities and require two very different hospitals to be transported to. So again, we need to determine the order in which we do things based on a specific focus to identify the underlying cause of our patient's condition. So moving on to components of the secondary assessment here, we must first identify the difference between a sign and a symptom. A sign is something that you physically can see or observe from outside, compared to a symptom, which is something that the patient will describe to you. So a complaint of shortness of breath, by definition, is a symptom. That's something that the patient says is wrong, that they describe to you. However, if you observe the patient in a tripod position, utilizing accessory muscles or general increased work of breathing, those would all be signs, things that you can physically see. And as you'll see here, you can utilize all of your senses, again, with the exception of taste. We don't ever taste anything. But you can utilize the sense of sight to observe your patient, the sense of feel to identify things like rigidity, or to palpate whether or not there's a crepitus within a fracture or an injury. We can utilize the sense of smell to identify the presence of incontinence or vomitus. We can obviously utilize our sense of hearing so that we can not only hear what the patient says to us, but also identify things like airway sounds, respiratory noises, lung sounds, and those types of things. And then keep in mind, too, that reassessment is a continual process. We are always repeating all steps of the assessment algorithm continuously throughout the entire duration of patient care. So as we begin taking a history or obtaining what we call a sample history, there's several components within that. And what we need to remember is that the OPQRST mnemonic is actually a subset of the word sample. And I'll illustrate what I mean by that. So as you see, OPQRST, if we were to look at it in outline form, is a subset of signs, right? Signs and symptoms, really. And the OPQRST mnemonic lends itself to the different types of signs or symptoms that we should be identifying and trying to determine that underlying illness or injury. So again, looking at this here, as we ask our OPQRST questions, they will fall into the signs and symptoms category of the sample mnemonic. Throughout our assessment, we're going to use 3 different components to perform the hands-on assessment, and that includes our eyes to observe, our ears to auscultate or listen, and our hands to palpate. Now, when I said hands-on, I included eyes and ears in this case, and the reason being because we're truly engaged in assessing the patient's physical presence and all of the things that are sticking out as far as how they're acting, what their overall condition is going to be. So a physical assessment doesn't simply have to be us touching them, but it can also be observing bruising and swelling. It could be listening to stridor or snoring or gurgling. All of those things are part of the physical presence of our patient. So from here, we're going to skip ahead to secondary assessment of the medical patient and look at some of the components of the medical assessment. We'll also talk about trauma assessment, but what you'll find is that they're actually very similar. There are very few subtle differences between the medical and trauma assessments. So the way that we determine how to assess or what to assess is really dictated by our patient's overall condition. If they are responsive and they're able to communicate with us and tell us what's wrong, it only makes sense that we will focus in on their chief complaint. For instance, if somebody says that they have abdominal pain, I should be focused on their abdomen first and foremost to assess the location of the complaint and try to determine what could be causing it. Now, my assessment may require me to perform other physical assessments throughout the rest of the body, but my initial focus should be on the chief complaint. Conversely, if my patient's unresponsive and they're unable to tell me what's wrong, I have to rapidly try to identify it. And I'm going to do that through a systematic head-to-toe assessment that identifies and assesses various components of the body that will lead me to identify as quickly as possible some underlying life threats. So again, if the patient can tell you what's wrong, focus on it. If the patient can't tell you what's wrong, rapidly search for the problem. So assuming that our patient is responsive, they're able to communicate with us, we're going to want to first ask a series of questions. That's going to give us the most information about the patient's condition. Let's consider a patient experiencing a heart attack. What physical assessment can I do that identifies the patient's having a heart attack? And the answer is really nothing. There's very little that I can do to physically assess my patient to determine that they're having a heart attack. However, if I were to ask them the appropriate questions, such as, what were you doing when this started? Do you have any nausea or vomiting? Are you short of breath? Does the pain radiate anywhere? Is there anything that makes the pain better or worse? All those questions and their subsequent responses will provide me a lot of information as to what's going on. And that's why we spend so much time identifying the signs and symptoms of various medical conditions, because it's important that as we piece together all those different clues, we're able to come up and determine what's wrong with our patient, and more importantly, come up with an appropriate treatment plan. As we talk about their past medical history, that can clue us into things that they may be predisposed for. A patient with a history of hypertension and atrial fibrillation is at increased risk for stroke or heart attack, or pulmonary embolism for that matter. So identifying those things could help us to come to a conclusion a little bit quicker. Performing the physical exam is going to be useful. If somebody is complaining that they're short of breath, then I can auscultate their lung sounds, and I identify that there are rales or crackles in both lobes, then that may suggest to me an underlying condition of congestive heart failure. Collectively, though, as I ask the appropriate questions, as I perform the appropriate physical exams, as I look at the overall condition of my patient and compare their vital signs to their underlying complaints, I should be able to quickly identify the most aggressive life threats and provide the appropriate intervention. So the best way to obtain a history of our patient's present illness is going to be by asking the patient directly. In the instance that our patient is unable to be a proper historian, let's say young children under the influence of drugs or alcohol, something like that, we can obtain information from family, bystanders, caregivers at a medical facility, or other people that may have pertinent information of what's going on. We also should consider the questions in which we ask. When we're trying to get a history of their current illness, it may be appropriate to ask open-ended questions. And we do that in a way so that we don't lead them on. So if I were to say to a patient, can you describe your chest pain to me? And they describe it as being sharp or dull or crushing or squeezing or something like that, that clues me in a lot. However, if I were to ask my patient, is your chest pain crushing? Their natural response is to listen to your question and more than likely agree with you. We want to be sure that we're not leading the patient down the wrong path or specifically leading ourselves down the wrong path by asking those targeted questions. Make sure to open it up, allow the patient to describe things in their own words, and then if you have to do some follow-up questions and narrow things down, that's fine. But it's important to allow the patient to explain things in their own words first. So we've talked about the chief complaint while we cover the primary assessment. Identifying what that chief complaint is should give us a little roadmap into what we need to begin assessing first and foremost. The OPQRST mnemonic is going to be important as we go through the medical components. This applies a lot less to trauma, right? If somebody falls to the ground and breaks their ankle, then we kind of know everything about the events surrounding it. Now, the one thing we do have to be careful with in trauma is that we don't allow the trauma to cause tunnel vision on us and we miss an underlying medical thing. So a patient falls down the stairs. Okay, obviously their injuries are secondary to the fall. That's pretty simple. But what caused the fall? Did they have a syncopal episode? Did they have a stroke? What is it that actually caused that underlying fall? And I'll tell you what, if in the event that a patient has a stroke and that leads to a fall down the stairs or a car accident or something like that, it's actually a higher priority to treat that stroke than it is the trauma. So we need to identify the potential for those types of things and again make sure that the patient gets the appropriate treatment plan and gets to the appropriate facility. So the onset, the provocation, the quality, all these things play into our overall questioning to try to help us better understand what led up to the current chief complaint. So onset is simply, what were you doing when it started? Were you sitting and resting? Were you exercising? Were you working at a desk or in a meeting under high stress? Provocation says, what is it that makes this better or worse? What if somebody is experiencing chest pain and they say that they sat down and they rested and it went away after 10 minutes? Hey, in that case, I'm thinking angina. If they say that they sat down and rested and it didn't go away after 15 minutes, now I'm thinking that it could be a possible heart attack. Quality, describing the pain. Is it sharp? Is it dull? Is it squeezing? Is it does it come and go, intermittently, or is it constant? All of those things will help us to identify what's going on. Region or relief, or also radiation. Does the pain travel anywhere? Does it go from the center of your chest to your left arm, from the chest to the back? Does it radiate from your right flank down toward the groin, right? Putting together maybe a kidney stone there. Severity then, on a scale of 1 to 10, 10 being the worst pain that you could possibly imagine in your life, rate it for me. And then time, when did the pain start? And if we go back to onset, what were you doing? And then we look at time, those two things may come together. It's important that when we listen to our patient and they're describing what's going on, that we are actively listening, meaning that we're not simply checking off boxes on our paperwork or going down a list of questions. This isn't a survey or a questionnaire. This is a conversation. It's a two-sided dialogue. And we need to listen to the patient's responses and make sure that if they provide us with additional information to address one of these mnemonic things, that we document that appropriately. If I ask the patient, what were you doing when this started? And they said, oh, well, I was doing the dishes about 15 minutes ago. And they go on to tell us the rest of it. And then all of a sudden, now we get down to time and we say, okay, well, when did this start? Since the patient already answered that question, it seems to the patient now that we're not actively listening to them. And ultimately, if the patient doesn't think that we're actively listening, that can really impact their perception of patient care. So then the remaining components of sample, right? OPQRST falls within signs and symptoms. We also have allergies, medications, pertinent past history, that last oral intake, and the events leading to the illness. A lot of times the patient's chief complaint, coupled with pertinent history, can really give us a clue as to what might be going on. Obviously, if a patient has a diagnosed history of a certain illness and they're experiencing signs and symptoms of it, they can a lot of times tell us, hey, yeah, this is, I have a seizure disorder, I have seizures all the time. We don't really have to kind of guess as to what the underlying cause is. But a new onset seizure without any prior history is a big concern, because now I'm not thinking necessarily that this is epilepsy or a chronic condition, but I start thinking of all the really time-sensitive and life-threatening acute conditions that can cause seizures. Is it infection? Is it a intracranial pressure? Are there drugs or toxins on board? These are all the things that are, again, they're non-self-limiting, they are acute, and they're much higher risk factors than having a simple epileptic seizure. So this is something I call the diagnostic funnel, and something I just kind of made up, but really it makes sense. From the onset, when we get on scene and we start performing our basic assessment components and we establish that chief complaint, there's just a plethora of possible conditions or causes for the patient's 911 call. However, as we start to ask the appropriate questions and get those answers, we perform more and more assessment components, we start to rule out different possibilities. And as we establish what we believe to be the underlying condition, we can again target that by asking specific questions, performing specific assessments, and eventually, as everything funnels out the very bottom, we should come out with one simple differential diagnosis that allows us to develop a comprehensive treatment plan to address it. So think about kids now. As I ask questions to kids, it's going to be a little bit different. I have to think about, terminology. I have to think about tone and compassion. I need to get down to their level and maintain eye contact with them. I need to make them feel comfortable in order for them to open up and start talking to me. So kids are a unique audience that we have to learn to communicate with. From here, the physical exam, again, let's consider that a patient is complaining of abdominal pain. I'm probably going to palpate the abdomen, both at the site of the pain and around the site of the pain, looking for abnormalities, rigidity, rebound tenderness, pulsating masses, all those other things. I'm also going to examine the skin physically to determine, are there rashes? Is there a bruise there? Is there swelling? What are some other things that could be causing this potential abdominal pain? Physical exam is going to include things like assessing lung sounds, palpating the abdomen, checking for pedal edema. When we do our trauma assessment, we're really going to cover almost every square inch of the body, starting with the head and working down to the toes, doing the front and the back. But in the medical assessment, even if we are doing head to toe, we're able to kind of skip around a little bit more. We don't have to physically touch the entire body, but we are going to identify or target certain areas that'll give us the best clues as to what could be going on. From there, then we want to be sure that we obtain that baseline set of vitals. As we talked about in the vital sign chapter, it's okay to do this concurrently with your sample history or physical exam, so long as you have the resources to do it at the same time. But vital signs should not delay your physical exam or your sample history, because ultimately they will provide you with the least amount of insight into what's wrong with your patient and provide you the least amount of insight as to how you need to treat them. This is a really valuable slide. It's a simple statement, but remember, a decision for prompt transportation of critical patients or those with specific complaints is part of a treatment plan. Sometimes our assessment will lead us to the conclusion that what's wrong with the patient is not something that we can treat in the field. And if that's the case, why are we wasting any more time? As soon as we identify that the patient's condition is something that is outside of our scope of practice or outside of our capabilities or resources, we shouldn't spend another second screwing around on scene. load the patient up, take them to the hospital. We need to be aggressive about performing interventions in the back of a moving ambulance. And that's something that you really need to practice. Obtaining lung sounds, obtaining a blood pressure, all those things are difficult in a calm, quiet environment where nothing is moving. They are even more difficult as you're bouncing down the road, the ambulance is shaking and rattling, you've got lights and sirens going, other traffic noise, ambient noise, everything else. There's just a lot going on there. But we need to become proficient in that. And the only way we do that is through practice and repetition, training our ears and stuff to work and be able to focus in on blood pressures and lung sounds and to exclude all that background noise. So, looking now at unresponsive medical patients. So the patient is no longer responsive, they're unable to communicate with us, they are completely out of it, and we have to use our assessment skills to kind of figure out what's wrong. This is a tough patient. They can't tell us, they can't provide us any clues, any guidance or direction. This is entirely on us to figure it out. So what we need to do is remain systematic. We don't want to skip anything. We don't want to accidentally miss something here. So we're probably going to begin with that head-to-toe physical exam. As you can imagine, asking sample history questions is going to be limited because the patient's not talking. We can ask appropriate questions to bystanders, family members, or healthcare providers if they're available, but generally speaking, that rapid physical exam is going to be the best bet for us. From there, again, we can do vitals once we have a baseline idea of what's going on with our patient, and we can use those vital signs to determine the overall patient severity and also to identify or confirm some of our suspicions with our differential diagnosis. So we're going to work from head to toe, and we're going to look for very specific things. I'm not going to discuss it much because it's difficult to visualize, but this is a skill that we will practice in class relentlessly throughout the rest of the semester. And as we move down, starting with the head and moving down to the neck, the chest, the abdomen, pelvis, lower extremities, upper extremities, and eventually onto the posterior aspects of the body, we are going to be looking for very specific things. So in the past, you were taught things like DCAP, BTLS, deformities, contusions, abrasions, punctures or penetrations, burns, tenderness, lacerations, and swelling, right? That's something you probably learned in first responder, and that's, again, a great mnemonic to help you remember things. Under no circumstances do I ever want to hear you say DCAP, BTLS when you're assessing your patient. If we're running a assessment scenario and I say, okay, what are you looking for in the chest? Don't say DCAP, BTLS. Say that you're looking for bilateral chest rise. You're looking for accessory muscle use. You are looking for tripoding. You are looking for skin parameters. Whatever the case may be, things that are specific to the chest. That's what I want to hear from you, because we need to know specifically what it is that we're looking for, not just kind of a shot in the dark and hoping that something stands out to us. Beyond checking the patient's body for physical findings, we can also look for things like medical ID devices. I do know that there are some people that are tattooing medical information on them now. Frankly, I don't like that. I think it's easy to kind of miss, but something that you should be aware for and to look for, okay? As we move on from there, then we're looking at vital signs and we're assessing those pulses, respirations, skin pupils, blood pressure. We'll also talk a lot about end-tidal CO2 and other components of vital signs. And in the event that we determine based on our assessment that our patient requires additional help or resources beyond what we can do, it may be appropriate to request a higher level of care, such as ALS intervention. Questioning of bystanders isn't much different than questioning the patient. We want to know what they saw, what they heard, what their general observations were, etc. For instance, I responded just a few weeks ago for a patient who was unresponsive, and as we arrived on scene, we found him laying on the side of the pool deck at a health club. And evidently what happened is the patient went unconscious in the pool, submerged, and his classmates were able to pull him out and get him out of the pool. So I had a lot of questions for these classmates. How long was this patient submerged? Did they witness any type of seizure activity? Did the patient have any complaints leading up to this? Are they aware of any prior medical history that the patient has? So I was able to, again, target the bystanders, the witnesses, with specific questions that were able to kind of lead me in the right direction in determining what could be going on with this patient. We also want to continue to observe different indications of mechanism of injury or nature of illness. These are things that we should be picking up during the scene size up, but we may see different clues or observe different things as time goes on. Remembering that, again, all components of the assessment algorithm are repetitive. They're cyclical in the fact that we continue to do them over and over and over again. We can also examine the scene for other clues. We can look at medications. If we're unable to determine what the patient's medical history is, if I look at their prescription meds, a lot of times I can get a pretty good idea of what's actually wrong with my patient. What are their previously diagnosed conditions? I can also look to make sure that they're compliant with their medications. Look at the date that the prescription was filled, look at the recommended dosing, look at today's date, compare the number of pills that should be missing compared to the number of pills that are missing. Are they forgetting to take their meds? Are they possibly overdosing, etc.? Okay, we're going to roll into secondary assessment of the trauma patient now. So the trauma patient, again, is almost identical to everything we've talked about. The primary difference here is that we're focused less on history and more on the current events. In addition to that, as we do our physical assessment, it requires a lot more touch, it's a lot more methodical, and it's going to be a lot more difficult to identify a lot of these underlying conditions. What we find out with trauma is that it's not just one single problem, right? We experience multi-system trauma quite a bit. And that means that, multiple systems are involved, a lot of a major potential for internal injuries that are hard for us to identify. Just a lot going on here. And we have to be really good at kind of gathering up all the information, keeping it organized, and being able to determine just how extensive the patient's injuries may be. We'll begin, just as always, by assessing things like ABCs, looking for that mechanism of injury. Based on some of our initial assessment findings, we should start kind of developing an idea of what could be wrong with my patient. Yes, I need to do that head to toe and identify things, but I should also have an idea based on mechanism, what I should be looking for specifically. If a patient's involved in a rear-end collision, I'm considering, cervical spine issues, maybe thoracic spine, those types of things. If they are involved in a fall from a ladder, I'm thinking, okay, where did they fall? What did they fall onto? How high did they fall? Those things will all play into it. So I should be kind of guessing based on MOI and some different scene clues. Also, just going back here, looking at patient's age or pre-existing conditions. So the extent to which a patient is injured is different depending on a lot of different variables, including age and pre-existing conditions. If I told you that a 22-year-old male fell off his bike going 30 miles an hour down the road, then okay, we'll have an idea of some of the injuries they may have. But now take a 70-year-old male fell off his bike going 30 miles an hour down the road. We know that there's a higher susceptibility for broken bones because the bones are more brittle. We know that a patient may be on blood thinners due to pre-existing medical conditions, which would affect his ability to clot in response to the trauma. There's just a lot of different things that those demographics will determine when it comes to assessing our patient and their overall resilience to the injury. So with the patients that are more minor, they have kind of localized injuries. We're going to focus in on that. If it's a soccer player that says that they twisted their ankle and fell, but they're still awake, they're alert, they're oriented, they're talking to you appropriately, I need to focus then on their ankle, their chief complaint, right? However, if it's a patient that has multiple injuries, maybe they lost consciousness, they had a concussion, or even unconscious unresponsive, those are times that I have to be, again, more methodical and aggressive in identifying and assessing the entire body. All right, so looking at the nature of the force involved, physics is a big part of trauma. How fast is a patient going? What direction of travel were they going? Or what direction of travel or what speed was the object going that hit them, that caused the injury? Considering different laws like an object in motion will remain in motion until acted upon by an outside force. That physics law is something that we can use in car accident evaluations. As I'm driving down the road in my truck at 50 miles per hour, if I were to hit a huge oak tree and the truck just stops on a dime, well, the first impact is the truck hitting the tree. The second impact then is my body continuing to move forward after the impact until my seatbelt or the airbag stops me. That's a second collision, my body into the truck. And then there's a third collision where my organs continue moving forward until they hit the front of my abdomen and chest, at which time they stop. So those three impacts are all indications of what could be going on. The speed at which I was traveling, the density of the object that I hit, all those things play into it. As we're doing our physical assessment, we can compare one side of the body to the other as well. And we can look for symmetry. Is one leg shorter than another? That would be a suggestion for a dislocation of the femur. Is one side of the chest rising higher than the other? Okay, is there a flail segment or is there a pneumothorax? So we want to be able to utilize the patient, compare one side to another, and look for that symmetry and uniformity. Evaluating is the color the same? Is it moving together? Those types of things. We can also palpate doing the same stuff. We're looking for different differences in temperatures. For instance, if a patient has a spinal cord injury, then the blood vessels below the site of the injury tend to dilate, meaning that there's a large pooling of blood in the lower parts of the body and the lower extremities. I can identify that because of the difference in temperature. The skin above the site of the injury is going to appear pale and cool to the touch, whereas the skin below the site of the injury would feel warm and more flushed. So again, just looking for all the differences from one side to another. Are their grip strengths equal on the right just as they are on the left? Do they feel everything on one side just like they do on the other? Or are there differences from one side to another? As we auscultate, we're listening for things like lung sounds, bowel sounds, anything else that may clue us in. Sometimes it's very difficult to obtain a palpable pulse. I could use a stethoscope to listen for a faint pedal pulse, or even a radial pulse or anything else if we're having a hard time palpating. Here's that decap BTLS that I talked about. A great mnemonic. You should use it to remember what you're looking for, but I still want anatomically specific things depending on the part of the body that you are assessing. Once we've assessed the physical components of the patient and identified the injuries, from there we can start to look more at past history and also gathering vital signs. Not that the past history is relevant, aside from the fact that, okay, could it have been a medical condition that caused the trauma, or could pre-existing medical conditions further complicate the trauma? And the vital signs, again, will just kind of clue us in as to the stability of the patient, and they can, from time to time, give us a clue on underlying injuries or conditions. But again, our most valuable, fastest way to identify patient issues is going to be through a physical exam. We can still utilize sample with trauma just like we would with medical. And in certain circumstances, it may be appropriate to immobilize our patients. We'll talk more about that when it gets to trauma. Nothing that we need to really address right at this time. So more often than not, our assessments are going to be rapid when it comes to trauma. We want to quickly identify what could be going on with our patients and come up with the appropriate interventions and treatment plans. The rapid assessment should only take, on average, about 60 seconds. We can sometimes multitask, having multiple providers assess different parts of the body, but best practice is going to be having a single provider perform not only the initial assessment, but all the ongoing assessments as well. We want to make sure that it's the same person that felt, a mass or felt swelling or felt instability that feels it again on the reassessment. And they'll be the best ones to determine whether or not something is getting worse, improving, or staying the same. We're going to talk a lot in class about the rapid assessment, including procedures and what to do, how to do it. So I'm going to just kind of casually click through these slides, knowing that this is all stuff that will be demonstrated and be discussed in the classroom. Be sure still to look over those slides. There's good information on there procedurally, things that you should be aware of, just stuff that you can read off the slides on your own. You don't need me to talk to you about it. When dealing with trauma, and even in some medical situations, it is appropriate to expose the area of the potential injuries. In the instance of unresponsive trauma patients, a lot of times we're going to remove just about all of their clothing so that we can visualize head to toe and quickly identify the presence of possible injuries. We can see the development of bruises or swelling, and we can just generally monitor the patient's condition. Anytime we're dealing with extremity injuries, we want to be sure that we're assessing sensation, motor function, and their circulation. Asking them to move their fingers, maintaining or assessing capillary refill or radial pulses, assessing their overall strength, whether or not they have any weakness, numbness, tingling, etc. So again, a few pictures just of determining or assessing those components there. With kids, keep in mind that the mechanism of injury for an adult, the severity of that mechanism, does not have to be anywhere near as intense for a child to develop the same severity of injuries. So again, what would be a minor impact to an adult could be a very severe impact for a kid. Moving in now to the detailed physical exam. So let's quickly recap. As we hear the tones drop and the call comes in, we initially begin our scene size up. We start thinking about what's going on at the scene and what we're going to do when we get there. When we actually arrive on scene, we complete formally the scene size up and the fact that we ensure that the scene is safe. We utilize appropriate BSI precautions. We identify the number of patients, we request appropriate resources, and we look at the mechanism of injury or nature of illness as potential contributing factors to the patient's condition. From there, we move into the primary assessment, which focuses on hands-on patient interaction. We determine what our general impression is. We establish the patient's chief complaint. We assess their mental status, their airway, their breathing, and circulatory efforts. And we determine the overall priority of the patient, determining whether or not this is a stay and play or load and go. From there, we transition into the secondary assessment. If the patient is conscious and awake, we'll focus on their chief complaint. If they're unconscious or unable to communicate with us, we will perform a rapid head-to-toe assessment to try to identify the underlying causes. From here, once we've completed all that, we roll into a detailed assessment. And we'll go back through and we'll maybe do another head-to-toe, or we'll reassess some of the same things we assessed before, but now we'll really take some time. Rather than simply trying to identify life threats, which is what we do in the initial assessments, now we're trying to identify all the other secondary issues that may be going on. We may not be able or equipped to treat those conditions, but it's still important to identify them, report that back to the hospital, make sure that those things get treated as soon as they can. So this detailed physical exam is exactly that. It's another head to toe, but it's slow, it's methodical, and it's looking for all the fine details. Now, this is typically going to be performed en route to the hospital. I shouldn't be doing this on the scene. This is only done if everything else is done and we have time to get it done. For some departments with short transport times, you may not get to a detailed physical exam if you're able to effectively manage your scene time like you should. A detailed physical exam is probably going to be the most valuable for our trauma patients, but can still be used equally between trauma and medical patients. This slide just echoes what I said a few minutes ago, that you only do the detailed physical exam if you get to it, if you have time. If you don't get to it, it's not the end of the world, but it is good practice if the time is there. So generally speaking, if a patient is not severely injured, they probably don't need that detailed physical exam. Case in point being the soccer player with the broken ankle. I don't need to go and do a head-to-toe assessment, listen to lung sounds, palpate the abdomen, and do all those other things. In this case here, if they simply are awake, they're alert, they're oriented, they're able to tell us exactly what does and does not hurt, and they're able to localize the pain only to their ankle, we probably don't need to go beyond that. We'll continue to reassess the ankle, we'll apply ice packs, we'll immobilize if appropriate, we'll check SMVs, and other than that, we're going to transport the patient. We don't need to continue to go overboard. Now we're going to jump into reassessment. So reassessment is something that we perform nonstop throughout the whole call, starting with scene size up and working all the way down through everything we've talked about so far. Reassessment is reevaluating everything that we've done to this point, checking to make sure that splints that we put in place were effective, assessing the quantity of oxygen that we're delivering to make sure that's treating the patient appropriately, looking for changes in the patient's mental status or airway patency, anything and everything. It includes subsequent vital signs and the ability to trend, compare those one vital sign to a next to determine if the patient is improving or deteriorating. All of that stuff is all found within the reassessment. Again, it continues on the initial steps. And what it's going to allow us to do is identify subtle changes that may not be as obvious. For instance, if a patient is found semi-conscious and not acting appropriately, we may get a baseline set of vital signs that identifies that their blood sugar is low. So we administer glucose, brings their blood sugar back up, but we notice that despite the fact that we increase their sugar level to normal ranges, their mental status has not improved. Meanwhile, we see an increase in their blood pressure. And as we obtain our third and fourth set of vital signs, we see that their sugar is still remaining within normal limits, but their blood pressure is continuing to increase higher and higher, and their mental status is not improving. This tells me that they could have some type of underlying head injury or trauma that would be causing this, potentially a stroke. And it is very possible that something like a stroke could cause a decrease in the blood sugar. So by reassessing and trending and identifying what we have and have not done that has been effective, we can come up with other potential causes that may be more subtle than the initial hypoglycemia that we came across initially. During the reassessment phase, again, typically en route to the hospital, this is an appropriate time to, strike up conversation with the patient if they're able to. Ask them about their life. Just try to demonstrate that you genuinely care about them, about their well-being, and also offer them a little bit of distraction from the injury or the illness itself, and just really helping to relate to them and making the experience as comfortable as it can be. We're going to repeat the assessments, or we're going to perform reassessments continuously, but by general rule of thumb, we're going to reassess everything, including vital signs, every 5 minutes on average for critical patients and every 10 to 15 minutes for less critical or stable patients. Now, that is just a simple guideline. I can tell you that there's patients that I'm taking a blood pressure every 2 to 3 minutes because I'm trying to trend and determine what's going on. And I can tell you that sometimes there are patients, especially our behavioral or psych patients, who are otherwise agitated, don't really want to be touched. I may only take one set of vitals on them because I don't want to agitate them. And from time to time, I may not take any vitals on them. However, the general rule of thumb is that we should always have at least 2 sets of vital signs for every patient that we come in contact with. And from there, we're going to go ahead and conclude. Now, you'll notice I probably only covered half the slides in this entire chapter. All of the slides are important, and I strongly recommend that you take the time to review the PowerPoint slides, but especially read all of the content in the textbook. There's a lot of good information in there. Just because I didn't cover it does not mean that it's not valuable. It means that there's nothing that I can provide you beyond what is simply provided in the text itself. So you're all capable of reading, and I encourage you to go through and review that stuff in detail. We'll practice the hands-on components in class. We'll do that extensively, and you'll have plenty of opportunities to ask questions and practice and refine those skills. Thank you very much for taking the time to listen.